The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/DMW860. Downloadable slides and practice aids are also available. Thank you for listening to Peerview Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now on to today's podcast.
Hello, everyone, and welcome to our virtual symposium talking about the ocular toxicities in multiple myeloma and opportunities for ophthalmology-oncology collaboration. I am Pranita Tulasi. I'm one of the faculty at Emory Eye Center in Atlanta, Georgia, and I have with me Dr. Lonio from Winship Cancer Center, also at Emory University in Atlanta, Georgia. This is our agenda for today, so let's just dive right in. Dr. Lonio?
Yeah, thank you. So let's start off with a patient that we share. We're going to call her Anne, who's a 76-year-old female whose story began probably about 9 years ago when she was diagnosed and treated up in the Northeast, received an IMiD and proteasome inhibitor-based combination as induction therapy, declined autologous stem cell transplant, stayed in remission for about 2 or 3 years, and then right around the time that her myeloma was starting to get more active, moved down to the Atlanta area. In the intervening 6 or 7 years, she's gone through bortezomib-based combinations, carfilzomib-based combinations, lenalidomide-based combinations, pomalidomide-based combinations, and daratumumab-based combinations. She's also seen elotuzumab in combination as well. She's had a median of, she's had somewhere around 7 or 8 prior lines of therapy and has a very good performance status, is now in her mid-70s, but really doesn't want to go in the hospital for any aggressive cytotoxic therapy, doesn't want chemotherapy sort of per se, in the sense that doesn't want to have transfusions and other kinds of complications or potential support. But has a good performance status and wanted to talk about additional therapeutic options. And this was right around the time of the approval of Bellamav. And so we began to talk to her a little bit about the potential adverse events and benefits of Bellamav in a patient with refractory multiple myeloma.
And this patient was then sent over to the eye clinic for ocular screening for any possible adverse events. She had a history of pseudophakia, so has had cataract surgery already. This patient also has had one vascular event in her eye that compromised her vision. But other than that, as far as her primary ocular side effects to expect for belantamab, we really worry about the front part of the eye, the ocular surface. So we know that these patients can get blurred vision and decreased visual acuity and dry eye symptoms. And really, these are primarily from punctate epithelial keratopathy and these microcystic changes that we often see on the cornea. But this isn't the first drug that's had ocular side effects.
Yeah, so it's interesting because if you go back through the history of myeloma, the real revolution in treatment probably started in the early 2000s with the approval of bortezomib, and in the mid-2000s with the combinations of bortezomib with either lenalidomide or thalidomide, the immunomodulatory agents. And way back then, even, we began to note that some patients were seeing some eyelid-related complications in the bortezomib-based approaches. I'll seek your guidance in terms of things that we can do to manage that a little bit. But just to give you a little bit of a history, if you fast forward through the next 10 to 15 years, we saw many other drugs that were evaluated and approved, including second-generation proteasome inhibitors, oral proteasome inhibitors, anti-CD38 antibodies, anti-SLAMF7 antibodies, HDAC inhibitors, EXPO1 inhibitors, and it really wasn't until September of 2020 when belantamab mafodotin or Bellamav was approved that we really saw the next drug that had any sort of ocular related adverse events as well. So maybe if you could talk us through a little bit of some of the things that you've seen with bortezomib in terms of ocular toxicity.
Oftentimes these patients present with, pretty significant chalasia. Usually these patients are coming in with meibomian gland dysfunction and blepharitis, so often irritation, redness, foreign body sensation, fluctuating vision. But it is not uncommon for them to kind of progress to having these chalasia that can be recurrent and can be sometimes resistant to our usual therapies. And they can be bilateral, they can be upper lid, lower, really quite significant. There's been some data on how to manage these, and it's really variable, and it sounds like it's really patient dependent. Our usual go-tos for chalasia or meibomian gland flare-up is really using hot compresses, artificial tears, and sometimes either steroid or an anti-inflammatory like oral doxycycline. These did seem to help some patients, but oftentimes the thing that seemed to work better was stopping the bortezomib along with the ocular therapy. If these chalasia don't resolve, again, this isn't an infection or anything truly dangerous or visually threatening, but it can be rather bothersome to patients. And sometimes we do have to excise them surgically, which is, again, usually not a big deal from an ophthalmology standpoint, but a patient can be quite scared of that.
And it's interesting because I'm not sure that this is a class effect for all proteasome inhibitors, because I don't think we see this with the same frequency with carfilzomib, which is an epoxy ketone based proteasome inhibitor. And many of us, at least in our field, and I'm curious about your input as well, feel that this may be the boron. It may be a reaction to the boron that is part of the warhead in bortezomib. Although, again, we don't really see it with ixazomib, the oral proteasome inhibitor, with the same frequency that we've seen it in bortezomib.
Yeah, I don't know if the mechanism is truly known for why this happens. They do think this is because of sort of the amount of the inflammation on the ocular surface that bortezomib particularly causes. And it seems to respond to steroid. There's some data that's looked at patients who were on high dose dexamethasone at the same time as bortezomib, and they had less frequency of these chalasia, suggesting that this is probably inflammatory. But it's I think really doing a true mechanistic investigation on some of these drugs can be quite difficult. Yeah.
So let me just ask, because you bring up a really important point, and whether or not it's ocular complications or other complications associated with myeloma beyond the eye, many times folks or colleagues will say, well, let's just pulse them with steroids and see what happens. And the reality is that our patients are usually on a fair amount of steroids already. And so the question is, how much systemic corticosteroid actually makes it to the cornea or the eye? And does local steroid administration really seem to enhance that?
I'll be honest, right? A lot of times with the chalasia, steroid pulses, I think, make us as ophthalmologists feel better, patients symptomatically feel better. Whether they truly resolve the chalasia is really very much up for debate. In fact, I think even within the ophthalmology community, there's a good chunk of us who do not think steroids are the answer for these recurrent chalasia, and some do. So I don't know if steroids necessarily would modify the side effect profile, but also, chalasia in the grand scheme of things from an ophthalmology standpoint, while unsightly and bothersome to a patient, are not sight threatening, whereas 40 milligrams of dexamethasone every single, on a prolonged use can be quite a side effect inducing. So I think a lot of times it is weighing the benefits and risks, especially when it comes to oral steroids. Topical steroids or even injections into the lesion itself, I think are really up for debate, and I don't know if they necessarily work any better than oral steroids when it comes to chalasia. Yeah.
Yeah, that's interesting. That's an interesting perspective, because I think we go back and forth on this with a lot of our colleagues in subspecialties.
I think sometimes in Right. Ocular surface, when in doubt, try a little steroid, sort of the approach. But I don't think, at least for this particular problem, it doesn't seem to be the panacea that solves these chalasia.
All right, great. So I do want to just take a moment to introduce at least the agent that we're talking about, belantamab mafodotin, or Bellamav, because many in the audience may not be very familiar with this. So this is a monoclonal antibody directed at a protein called BCMA, or B cell maturation antigen. And BCMA is a really important target in myeloma because when BCMA, which is on the surface of most of the cancer cells, interacts with its ligands, APRIL or BAFF, it induces tumor cell proliferation, drug resistance, and other things that the myeloma cell likes to do to sort of stay alive. And while this is an antibody drug conjugate, and the immunotoxin is something called MMAF, and don't ask me to try and pronounce the long version of that, but MMAF is a spindle poison, basically, that does have a known side effect of potentially having corneal adverse events associated with it. And while this is an antibody drug conjugate, so the MMAF is attached to the antibody, it does allow for ADCC and CDC as well. So it's not an IgG4 where it's sort of immune silent. It does have the ability to engage in the immune system as well to potentially induce tumor cell death. So this, for us in myeloma, is a relatively novel mechanism of action. We don't have another antibody drug conjugate approved in myeloma. And while other diseases do have antibody drug conjugates, they may use a different immunotoxin other than MMAF. This is one of the few agents that really uses MMAF in this situation. So I'm going to let you walk us through some of the effects of Bellamav on the cornea.
Right. So it primarily affects the cornea. For our non-ophthalmologists in the group, the cornea is the very front part of the eye that highlighted in yellow that lets light through, and it's normally nice and clear. It has very little opacification, and the clearer the cornea, the better the visual quality and acuity the patient is going to notice. And cornea has 5 layers, but really our layer of interest when it comes to this particular drug is the epithelium. And as with the epithelium in any other part of the body, right, we need stem cells that regenerate and keep that epithelium healthy and keep that epithelial barrier sturdy so that the rest of the cornea is well protected. In the cornea in particular, the stem cells, we think, primarily reside in the limbus, and they multiply and proliferate both centripetally as well as from the basal to the surface layer. And we think, and again, this is still something that's being explored, but we think Bellamav causes toxicity to these limbal stem cells by sort of a off-site cytotoxic payload deposition, which then induces apoptosis. But these cells don't just disappear; they still migrate centrally, sort of that centripetal as well as from the basal to the surface. Migration happens, and that's really what induces a lot of the ocular side effects that we see in these patients. So when it comes to these, really, the predominant side effect that tends to be visually very significant is something called microcystic changes we see on the cornea, and they're a little bit unusual. We do see microcystic changes on the cornea from other pathologies, but they are usually a secondary reaction to something going on deeper in the cornea, like high pressures in the eye or lots of swelling in the cornea. This, on the other hand, is truly intraepithelial microcysts without involvement of the underlying stroma or the remainder of the cornea. And they're a little tricky to see. Oftentimes you do need to magnify quite a bit, and really retroillumination helps see them much better. And they, exactly as we would expect from the mechanism, are peripheral at first, and they gradually migrate centrally over time. And, for my ophthalmology colleagues, if you've ever seen Meesman's dystrophy or some of these true intraepithelial diseases, it oftentimes looks like that. But again, the underlying stroma is very clear. The endothelium is normal. The pressures are normal. So this is really, truly an epithelial pathology.
And do you need to go back through, so you mentioned pressures or underlying epithelium. If you don't know a patient's on Bellamav, will you investigate those things? Whereas if you do know, you won't necessarily. I'm just trying to think of how you narrow the cause in this situation.
Right. So, I think anytime we see these microcystic changes, there is a fairly focal differential that we think about. And if I did not know this patient was in this particular drug, then I think, I'm certainly in my head thinking, okay, what's causing these? Is their pressure high? Is their cornea failing, and is their cornea thicker than normal? Those things certainly are in my differential. But oftentimes it's, the microcystic changes tend to be the very late state change in those other pathologies. So it's not, it doesn't tend to be a huge conundrum. The only other time I've seen these particular types of microcystic changes is in patients with a particular genetic disorder called Meesman's dystrophy, and they come in oftentimes knowing that they've got a family member with this, or it's not something where it's a diagnostic mystery generally.
And from a timing perspective, because I know you were partnering with us on some of the really early phase studies. What's the sort of early time frame or the late time frame that you would expect to see changes if you're going to see them?
Yeah, really patient dependent, but I think on average, dose 3 or dose 4 is when I've seen these microcystic changes be a prominent part of their presentation. I've had patients where dose 2, when they come in for their screening for their second dose, they have some. I have patients that I've seen where they've gone many doses without any microcystic changes whatsoever. And it's unclear why patients seem to react differently, but it is often that dose 3, dose 4 screening exam that I'm seeing these. Again, in the early stages, they tend to be peripheral, they tend to be asymptomatic, and really don't cause many problems. It's really as they migrate more centrally that most of the problems tend to kind of pop up. Yeah.
Got it. Interesting. Yeah.
And these are not the only presentations in Bellamav. Obviously, microcystic changes were seen in the majority of patients going through this particular drug in the DREAM2 trial. 69% had their first event by dose 4. And not everybody who has these has symptoms, though. Only about 25% of patients reported blurred vision, and 15% had dry eyes. So oftentimes patients are a lot less symptomatic than we would expect given their findings on the cornea. I'm trying to find a great picture of these microcysts. They're just hard to image. It's really hard to capture them on slit lamp imaging. But, I had this one particular patient who the first picture is really them before starting Bellamav, and they progressed to mild peripheral changes on the second picture. And a really third one is when I think it starts becoming a little bit more obvious, where they are, almost a concentric ring around the cornea, sparing the central visual axis. And this particular patient did progress further. She did have involvement of the entire cornea. And once it got to that stage, she had some underlying stromal, very, very mild stromal haze and a mild edema as well, more reflective of kind of the dysfunction of the epithelium than any true inside the eye pathology. But remarkably, dose reduction, and I think we held a dose in this patient for a couple of visits, she returned back to normal, entirely back to normal.
And I think that's an interesting point that often some of my oncology colleagues don't necessarily appreciate, that with dose holding or dose modifications, you can have resolution of both the visual changes as well as the slit lamp exam changes. It seems to me that the slit lamp exam changes may take a little bit longer to resolve, but that the visual acuity, maybe because of the pattern in which it presents, peripheral versus central, that seems to resolve quicker.
Exactly. As they resolve, also tend to clear centrally first and then gradually clear in the periphery. Absolutely, sometimes the vision recovers much sooner than their slit lamp findings. These patients also have a lot of punctate epithelial changes. And these, as ophthalmologists, we are much more familiar with when it comes to treating dry eyes. Oftentimes, they just have a band of, punctate staining, as we would expect kind of inferiorly. But sometimes, especially if their microcystic changes kind of persist or progress, their punctate changes can be very diffuse, and they can almost have a whorl-like pattern that suggests, true limbal stem cell deficiency that has led to these punctate changes. But again, they all resolve over time, which is very reassuring.
Interesting. Yeah.
These tend to be the more symptomatic, honestly, than the microcystic changes when it comes to patients' symptoms. Yeah.
And it's the same pathophysiology.
Unclear, right? These, so punctate changes really are just suggestive of an unhappy epithelium,
Okay.
right? So obviously, if we think of the limbal stem cells not being healthy, epithelium is not as healthy, but the pattern of staining is more like a typical dry eye kind of inferior band of staining rather than that diffuse staining I would expect if it is a limbal stem cell related etiology. But these do respond to our typical dry eye therapy. So using what I would use for any other patient that walks into my clinic tends to work for these, whereas those microcystic changes really just have to run their course. Yeah.
And I know you were part of the sub-study with us as well that looked at corticosteroid eye drops as a prevention, sort of like cytarabine related corneal changes as well. And I guess the irony of a blinded study with an ophthalmologist is not lost on me. But in that randomized study, there was no benefit for the steroid eye drops.
No benefit. If anything, we saw patients coming in with ocular hypertension and some of the more steroid induced glaucoma and other issues. Really didn't notice any change as far as their dry eye, presentation or their progression of their microcysts. So I think that particular therapy, I think is safe to say, is probably not useful in this particular subset of patients.
Yeah. Okay. All right. Well, let's continue on then. So this patient, having gone through all that and sort of told her what some of the adverse events, the possibility of those adverse events might be, received Bellamav at 2.5 mg per kg, which is given one dose every 3 weeks. It takes 30 minutes. For the first dose or two, we might give a little bit of steroid pre-medication to reduce the incidence of infusion reactions from a humanized monoclonal antibody. But outside of that, it really is a pretty simple treatment to give. Doesn't require frequent visits to the office from our side. As you mentioned, the keratopathy is probably by far the most frequent adverse event that we see. The other adverse events are really related more to the toxin from the perspective of its impact on bone marrow function. So we do see thrombocytopenia, anemia, and neutropenia, which are on-target effects, particularly within the bone marrow. But those occur at a lower frequency than the keratopathy does. And as hematologists, most of us are pretty used to dealing with those issues and complications. And I can't think of a patient we had to withhold drug because of a heme tox event, as opposed to other things along those lines. So as we begin to think about putting more and more patients on Bellamav, there are some things that we begin to think through. And I think, the collaboration that we set up with you was really critical for us to be able to get patients seen and evaluated and make sure we've got that partnership set up on the front end. At least for us, the timing of the referral is often dependent on when we need to start, and you've been very gracious with your time in fitting patients in, but also understanding what's really required in the pre-exam piece, how much time that requires, what do subsequent follow-ups require? Do you want to talk us through a little bit of that so colleagues on both sides of the fence can understand what we're asking?
Yeah. Usually, I think, again, I was in sort of a unique situation because we were part of a clinical trial. But usually these patients came in on the morning of their infusions because just to simplify their travel and things like that. And it seemed from patient complaints occasionally that ophthalmology exam took longer than their entire infusion. Um, so, a key to these patients is really getting a great vision. And that sometimes is challenging. These patients are pretty dry. We sort of have to coax them and coach them into, getting the best visual acuity possible. And the other key thing about examining these patients is they need a refraction each time because their refraction does change subtly. So even if they they may, subjectively feel like their vision's a little blurry. Oftentimes, with a slight change in refraction, they do see much better. And that takes some time as well. We did, as part of our study and our collaboration with you, dilate every patient for every visit. But that I don't think is necessary once, as a clinician is pretty good at looking for these microcysts and gets very comfortable. Certainly helps to dilate and have that kind of retroillumination at slit lamp for examining these patients, but it's certainly not necessary. Since that initial experience, we have just been seeing these patients in the kind of the few weeks before their first infusion. And then, I think about a week after their infusion or a couple weeks before, just depending on their timing and where the patient's coming from and their travel capabilities and things like that. And that's made things a lot easier because patients can really come in at their convenience, get an eye exam, and then come on to get the infusion without having to wait in the eye clinic and having a long, long day ahead of them.
So one of the questions I have for you, because you really mentioned the challenges in assessing visual acuity, which is really important for us to understand the impact of the drug. This is an older patient population that likely probably has some level of cataracts to start with. And then in this patient's story, 8 to 9 years of chronic corticosteroid administration, which also raised the risk of cataracts. So how do those play into baseline assessment, and how do they interact with the epithelial changes that may occur with Bellamav, and how do you tease that all out?
That's a great question. And you're right, these patients oftentimes have multiple ocular comorbidities. This particular patient has had cataract surgery, but that's not often the case. Patients come in and they do have significant cataracts, and assessing visual acuity and change in visual acuity and saying, all right, I think a lot of this visual acuity changes from progression of cataracts versus their microcysts is sometimes a subjective call. Ideally, in a dream world, these patients come to us beforehand and we optimize their ocular surface and we take care of anything elective like cataracts prior to them starting on Bellamav, give them the best pair of glasses they can get, and then sort of get them enrolled in this study. But, that's not really the situation we run into. Thankfully, presence of cataract in the eye doesn't change sort of the incidence or progression of the microcysts on the ocular surface. They do tend to be independent of each other. But, in certain patients with advanced cataracts, even a few microcystic changes can profoundly change their visual acuity or their perception of visual acuity versus a patient who has no cataract or has very mild lenticular changes. The other thing we've kind of discovered through this process is these patients have been sick for a long time. So they have some vascular events in their retina. They've had a vein occlusion or arterial occlusion. These are not simple, straightforward patients with completely healthy eyes otherwise. And again, it's really challenging to know how much of their visual acuity change is from the cornea versus other pathology, which is why I think that baseline exam really helps. Because we know, all right, this is her baseline vision with, the best correction we can get her. And, we assess any change from that particular standpoint. And I think it helps if a patient is seeing the same provider or the same set of providers on a, kind of prolonged basis during this, as long as they're on this drug, because I think sometimes these calls are more subjective than we would like for them to be. I have had one patient where we did need to do surgery while they've been on Bella, because their cataracts progressed to the point where it really was difficult to say whether visual acuity was from the cornea or the cataracts. But that was more, I think, the exception than the rule in general.
And let me ask a question that I often get from some of my colleagues, which is patients that have had, and you may not have had experience with this, but it's certainly worth thinking through, corneal transplants or LASIK. How does that impact either of this in terms of assessment?
Yeah, that's tricky. Definitely makes it a little bit more challenging to assess these microcysts. Oftentimes patients who've had LASIK or cornea transplants have some ocular surface disease to begin with. They may have some underlying dryness and things like that. They are also the set of patients that, especially a cornea transplant patient, they may have microcysts from other causes, like a transplant that may be functioning less than ideally. Again, it can definitely make things a little bit more challenging. I think it really, again, helps if we can optimize their eye health prior to starting Bella. So if they had a transplant that looks less than happy, maybe repeating a transplant and getting them optimized from that perspective before we start them on this particular drug. But I know sometimes that luxury of time may not always be there. Yeah.
Interesting. Okay. So I think on this one, this really speaks to some of the frequency of exams around dosing. And I think it's important that from the REMS perspective for oncologists, there needs to be an ophthalmologic exam done for the first dose within 3 weeks prior to that first infusion. So that does give you a little bit more flexibility. Unfortunately, we often don't know 3 weeks beforehand that we want to give the drug. The patients come in and we often have to make a quick decision about starting them. And usually a week or so is about as much lead time as we can get. And then for each subsequent dose, we need an ophthalmologic exam as well. We typically try and do it, as you mentioned, the morning of, so they see you in the morning and then they see us in the afternoon and get their infusion. But I think that there is flexibility to allow it for a certain period of time prior to that next dose being administered, to allow for perhaps people that don't have the luxury of an ophthalmologist in the same complex as an oncologist to get seen on the outside before they come in.
Right, absolutely. And I'm, especially some of the fragile patients certainly appreciate not having to spend all day at a doctor's office, I think, because it can be quite tough on them to really spend all that time, bring their lunch, bring their loved ones, especially through COVID. I think it's been quite challenging.
Yeah, absolutely. All right. Go ahead.
Well, usually, I when they come in for their baseline eye exam, I notice that their primary anxiety, so to speak, tends to be about their ocular side effects. And I think a lot of it is, because they've had such excellent counseling from a hem-onc perspective, that these patients often come to their baseline eye exam knowing that the primary challenge with continuing this drug may often be their ocular side effects. I'm curious about what you tell patients before they come see an oncologist or ophthalmologist.
Yeah, so we will go through that, and what I try and do, and we're going to come to the absolute frequency of certain ocular events across the board, but whether it's in the chat rooms that patients are part of or they're following along, I will tell you that most patients, at least many savvy patients, are following along to the big meetings that are occurring and seeing what people are saying about it. They know that the keratopathy is an issue with Bellamav. And we tell them that, our pharmacists sort of advise them on that as well. And what I tell most patients is that everything that we've seen to date has been reversible, and that in most patients we're able to find a dose and schedule that allows them, if they're responding, to continue to get benefit. I think you mentioned and showed some very nice graphics of what you can expect to see. There was in DREAM 2 one patient that developed grade 4 with an ulcer, that patient actually had complete resolution of that ulcer and continued to receive Bellamav. And so even severe events like that can resolve, and patients can, with the right supportive care and dose modifications, can stay on therapy.
Yeah. And then that's usually something that we echo as well. I oftentimes discuss with patients that there are certain things we can manage, like their dry eye and aggressive lubrication, 4-6 times a day, and lots of hot compresses and things like that do help them symptomatically. And the patients often come back and say, you're right, that does seem to make things better. But they are all aware that these microcystic changes are something that they are more likely than not to encounter during their infusion. And they are all aware that that may lead to dose being held. But I do kind of emphasize exactly what you said, which is all of these changes seem to be reversible, and there's no reason not to expect that their visual acuity will not go back to baseline. One thing that I do want to highlight, though, is sometimes what an eye doctor sees their vision to be. When we keep them in a nice dark room with this high definition screen and optimizing their refraction, before getting a vision, may not be what they are practically seeing on a day-to-day basis. And it's hard to give them a new pair of glasses every single visit because we're just chasing our tail at that point. And that is something that I think is a little bit hard for patients on a practical basis to get used to, which is they may not feel like they are seeing well enough to do their reading at night. But there is little that I can, besides just saying, just wait it out and give it time, and treating their ocular surface as best as possible. There's little that I can acutely change in these patients sometimes, and that can be something that's frustrating to them. But I also know these patients are incredibly motivated, and they are often out of many treatment options, as you discussed. So these are just quite inspiring patients who just kind of keep going, even sometimes when their vision itself is quite compromised.
Yeah, no, I appreciate that. And again, I think the key is you really do need to have those exams prior to each dose to really figure out together whether it's safe to continue dosing, whether we need to have a hold or a dose modification, or if there's something else going on.
So just, I wanted to point out this particular scale, this Kva scale, and this is what we as ophthalmologists have been asked to fill out anytime a patient comes in to see us. Some of these are fairly straightforward, grading mild superficial keratopathy or, mild microcysts are, fairly easy to tell. Obviously, change in best corrected visual acuity is pretty objective and easy to document. But sometimes they are not always quite as clear cut as we've kind of experienced with some of our patients together. Especially that grade 2, where it's moderate, can sometimes be a little bit subjective, where there's some subjectivity to quantifying how many microcysts I think I see on an exam. If there is any question about whether a patient falls into grade 1 or grade 2, how do you address that? What is your general approach?
Yeah, I think it's interesting because from our side, the real question is the grade 2 that has moderate but does not have changes in visual acuity is a little bit of a gray area, I think, because I think the recommendations are to hold the dose if they hit grade 2. And we, at least, I think early on went on and got some clarification on is it and or between those two, because I think that is a little bit of a challenge. And certainly if that occurs in the first cycle before you have a chance to fully know whether they're getting benefit. If they're not getting benefit, then it's easy. Then you don't continue. But if they are getting benefit, then I think it becomes a risk-benefit ratio that we talk through. I think it's important to recognize that at least in DREAM 2, when patients did have dose holding for following these, the Kva scale-based assessment, roughly 80% of patients actually maintained their disease status or improved their disease status. It was really a minority of patients that had progression because of dose holding. And so You know, particularly in older, frailer patients, my motto is it's better to keep them on a low dose for longer than to keep them on a high dose for shorter. And so that same sort of mentality enters in here. If it's a borderline call and you think they're getting benefit, then hold the fort and try and keep them on therapy by not having them experience pretty severe corneal events. So
that sounds good. Yeah.
So I think there are a couple of questions I think that came in from the audience as well. So why don't we talk through this a little bit? We mentioned a little bit on the pre-existing eye conditions, whether it's LASIK or corneal transplant. So are there any other eye conditions that you would be cautious about, or call me up and say, do we need to do this? Can we think through this? Or this is going to be a little bit more challenging?
You know, no, I can't think of practically any other patients that have had any pre-existing eye conditions where I was hesitant about starting Bellamav. But, you know, a patient with limbal stem cell issues for whatever reason, you know, maybe a chronic contact lens wearer for, you know, decades, or patients with chemical injuries to their eye, or any other pre-existing limbal stem cell pathology that I see on exam, you know, there's just not data on what's going to happen to those patients. You know, there's not enough information to know if their eye will kind of recover from any insult that you know, Bellamav can do to their limbal stem cells. Those may be the only patients where I would hesitate in using this drug. I have had many patients who have retinal pathologies, cataracts, you know, vascular events, optic nerve events, glaucoma. All of those patients, we've been able to safely keep them on Bellamav and optimize their ocular surface without too many issues. But I think that's really the only particular patient that would give me pause.
Okay. And, you know, this, hopefully, as we get through the next few months, the next question will become less and less relevant. But the COVID impact on sort of seeing two specialists in one visit, you know, at least at our place, we've not noticed a significant effect because once they're in the complex, they're in the complex. But I can imagine that would be an issue if everybody weren't in the same place.
I agree. I mean, it's been thankfully okay so far. And, you know, these patients are very, very careful, and we have done the best we can in our eye clinic to make sure it's a safe experience for them. And you know, given that they're immunocompromised too, we certainly try and get them in and out and not keep them in the eye clinic as, you know, for a long time. But I know for patients in particular traveling to, you know, multiple locations, it's certainly been an anxiety-provoking experience. But it's been okay so far. And again, like you said, hopefully this is an irrelevant question in about, you know, 3 to 5 months.
Yeah, yeah. So you'd queried me in terms of what we talked to them about ahead of time. So I think we've covered some of that. I do think it's important that at least on the oncology side, that you both the provider and potentially a pharmacist spend some time with the patient, which is what we do for every new change or start in chemotherapy, to make sure that somebody other than us is giving them information, because the first time they hear something, they may not necessarily, it may not register. So that second person that gives them information often carries a little bit more long-term retention with a patient. And so I think, you know, I won't say that you can't talk about it enough, but what you don't want is a patient to have an event that impacts their vision and they claim they never heard that that was a possibility at all. So I think that is important.
Yeah. Or for a patient, you know, for the you know, for your information to sink in, right? It's really that second or third visit that I really, you know, realize the patients are paying a lot more attention to everything I'm saying. You know, the first visit, a lot of times they're like, yep, I guess I'll experience it, but it's hard to know what you can't imagine.
Right.
And I think it's really once they start noticing some dry eye issues or some distortion in their vision that, you know, those, you know, really that third visit is when they're all paying attention to every single drop change I make or every single suggestion I make. And, you know, these patients, I think, you know, they're definitely ones that as time goes on, their compliance gets better, not worse in terms of any changes in our regimen that we make, for sure. Yeah.
Yeah. Yeah, and I think this last question that came through really is an important one. And as you mentioned, I think you're right, having the same eye care professionals see the patient over time is probably important for consistency of findings and interpretation. I would argue that I think you want maybe one or two ophthalmologists that as an oncologist you partner with, so that you have that relationship and understanding of what one is asking of the other. And you sort of cement that relationship. I think, as I said before, you all have been very good about trying to get folks in and make sure that they have somewhat of a streamlined process, understanding the nature of what we do in terms of treating patients and the timing. And you just got to have that agreement that that's going to happen in advance to make this really work.
Mm-hmm. Absolutely. And, I think once we as ophthalmologists understand the reason or the importance of timing, oftentimes, they're not high intensity workups in clinic, or it doesn't take a long time to see them. But I think it is key that I know there's a reason I'm seeing these patients on this particular day, and that this is not a patient I can put off till next week, or, this is not a patient that, can be avoided being seen in this particular day because, X, Y, or Z. And I think that's really important. And I agree with you, having a partnership with an oncologist who, especially for some of these difficult patients, we can work through together makes for a better experience for us as ophthalmologists, and also for the patient, knowing that there is that communication that's going on.
Yeah, and I get, the other piece is that there are other drugs now, not just myeloma drugs, but other cancer drugs that are having ophthalmologic consequences. I know in urology, there's also an antibody drug conjugate that apparently has ocular toxicity as well. So this is coming more and more frequently as we get new targets and new ways to deliver therapy. So this partnership, I think cardiologists have figured out, have partnered nicely with oncologists, renal specialists have done the same. I think this is just an extension of that family.
I agree.
Yeah. All right, so let's get back to this case maybe and see what happened. So this patient ended up having grade 2 keratopathy on infusion 3. You said between 3 and 4 is when it usually shows up. So this one was 3. And the BCVA dropped 2 lines, and the infusion was subsequently held. So I think this is this happens. And in this patient's case, this patient has actually been on therapy for over or close to 2 years now, if I remember correctly. And this seems to happen almost every other visit. So for her, the Q 6-week dosing may be better than the Q 3-week dosing because functionally that's what she's getting, and she's had good disease control. So it's interesting. The half-life of this is so variable that you can see these kinds of intermittent dosing being effective, whereas in other patients they need the every 3 weeks, or in some patients they need every 9 weeks in terms of dosing. So this was a great example. And here are just some modifications that we take in terms of what to do. Again, we take our cues from our ophthalmology colleagues. If you see change in BCVA, 2 to 3 lines with a visual acuity not worse than 2200, then again, that's a grade 2, and we would withhold until we see improvement and then resume at the same dose. And that's different from a grade 3 or grade 4, where you would hold and then resume at a lower dose, depending upon the severity of the event. I guess grade 4 always has a corneal epithelial defect. Is that correct? Or is there other ways to get to grade 4?
That's really how they've defined it, is, if I am seeing a corneal epithelial defect, that by definition is grade 4. And these aren't, I know, theoretically, these aren't patients that they're pretty miserable if they have a grade 4 event. And this can be a very serious thing that can progress to an ulcer or even perforation. So hopefully our goal with our partnership is never to get to that stage, hopefully. And it's been, at least so far, our experience has been that we've not really had any go to grade 4, and we've had only just one patient in all of DREAM 2 that had a grade 4 event.
Right.
Yeah.
So I'm going to go through this just a little bit here because I think this was a nice graphic description of the frequency of keratopathy in DREAM 2. And so if you look at all 95 patients here, what you'll see is that roughly 72% of patients had any kind of keratopathy at all. That's grade 1, 2, 3, or 4. You know, what I think is really important is, again, that was by far the most common adverse event that was seen, was keratopathy of any grade at all. If you look at patients that had symptoms, and again, the most common symptoms, as you mentioned, were blurred eyes, blurred vision, or dry eyes. That occurred in about 50%. So that was the most common adverse event. And that might be mitigated a little bit with the preservative-free lubricating eye drops in terms of symptomatology. It really was only 18% of patients that had change in their BCVA to 20/50 or worse. So only 1 in 5 patients actually had significant changes in visual acuity. And as you mentioned, only 3 out of 95 patients actually had to stop the drug because of corneal adverse events. So this, I think, puts it into perspective. And this graphic, I don't know we showed this graphic, but we talk through this when we see patients to reassure them that the most common things that they're going to experience are dry eyes and blurred vision that can be mitigated, or itchy eyes that can be mitigated with the eye drops, but that the vision changes are really relatively a minority across the board.
Yeah.
So do you want to take us through this?
Yeah, so the main thing is these patients do need that eye exam, because sometimes, just as we discussed, symptoms don't always correlate with exam findings. So a routine exam, especially with a good refraction and a good slit lamp exam with fluorescein staining, should be able to identify their keratopathy and their microcystic changes. And the really reassuring thing is that these are manageable, these are reversible with the dose modifications. And just as you said, holding a dose or modifying the dose does not, in the majority of patients, seem to impact their response to therapy. And I think that is a pretty key thing for me as an ophthalmologist to know, and also for a patient to feel reassured that we can keep them on this drug without necessarily impacting their response to the drug. And generally, in fact, in most patients, the symptoms did improve just with time.
Yeah, and again, just to put this is a lot of work in terms of the support and things that you all do to help us keep patients on therapy. If you look at the 2.5 mg per kg dosing in terms of duration of response, so among responders, the median duration of response was somewhere around 11 months. And while that may not seem like a lot, particularly in the context of newly diagnosed myeloma, this is one of the longest durations of response for any drug that was approved in refractory myeloma. Typically, you're in the 3 to 6 month range for DOR, so it's almost double what you'd expect to see in this situation. So I think that, to me, DOR is a composite of efficacy and safety. And so that balance of safety is allowing patients to stay on. And we couldn't do that without the partnership of our ophthalmology colleagues in order to make that happen. So I wanted to just briefly talk through another case as well. And this was a patient who was on a clinical study of Bellamav, bortezomib, and dexamethasone. This was a 65-year-old lady, standard risk myeloma, had a transplant as well as induction therapy, not as heavily pretreated as the last patient that we talked through, but certainly had seen a fair amount of treatment as well, and was started on Bella in combination with bortezomib and dexamethasone. And in terms of the toxicity that she had from Bella, grade 2 after 2 doses, dose was held until it resolved to a grade 1. But interestingly enough, she did have some of the eyelid toxicities that we're mentioning that we talked about earlier on. So sort of a double whammy in terms of both the Bella and the bortezomib associated ocular issues. I don't know if you wanted to talk through your experience in seeing this patient.
I've seen her now almost a year, and she's had a great response from the Bellamav, but she's had toxicity from every single drug that she is on for the multiple myeloma. She gets grade 2 disease after 2 doses. She gets held dose for usually for 2 cycles. She's back to normal. back on the cycle and gets a grade 2 disease again after 2 doses. So she has a very predictable sort of cycle of response to the Bella. Her main issue, and this is what she complains about more than anything, is really that chalasia that she keeps getting. And, this patient basically, I think she does hot compresses like 4 times a day. She's on chronic doxycycline, and I do not have her on any steroids, but I do have her on some erythromycin ointment. And her chalasia always resolve after a few weeks. But, I think she's just chasing chalasia from one eyelid to the other. And, she's had a great response from this particular combo of medications. So she stayed on them despite kind of the eyelid issues. The more recent issues that's come up is her cataract has gotten a whole bunch worse, almost to the point where we can't quite tell if her visual acuity is from the cataract or from Bella. So actually just did her cataract surgery a couple of weeks ago. We did hold all therapy for a couple cycles while she was, undergoing cataract surgery, and she's done great. She's done great, at least from the cataract surgery standpoint.
Yeah. I mean, I think it's a great case of, yes, the Bella was an issue, but it wasn't actually the worst issue from the ophthalmologic perspective. There were other ones that are chronically associated with the other drugs that we administer. And I think the chronic steroid use that we sort of take for granted in myeloma really can have significant ocular events. And I think that story is a great one in terms of how to manage all of those together in one time.
Yeah. She's done great though. No, so this won't be the first time or the last time I'm going to see patients with multiple comorbidities and multiple ocular side effects from these drugs. In general, I think our recommendations really tend to be tailored to the patient's disease and their perspective. We know from some small case series for at least bortezomib that they tend to respond to just sort of local therapy and really only need discontinuation of the bortezomib if their chalasia do not respond to topical therapy. But they do seem to, when the drug is stopped, they do seem to resolve eventually on their own. But as far as managing the ocular toxicity in multiple myeloma, the risk evaluation and mitigation strategy program really helps all of us make sure that we are on the same page. I know you see the other side of these patients, Dr. Loniel.
Yeah, I mean, I think, REMS is not something new to us. We've had it for thalidomide, lenalidomide, and pomalidomide for a long period of time. And it just requires some safety checks to make sure that we're not putting patients at risk. And that partnership with ophthalmology is really key to doing REMS in an effective way. I don't see personally REMS as a barrier. I see REMS as a way to ensure we're able to deliver safe care consistently to a patient. And it's a nice algorithm to help us really be able to do that.
And, basic recommendations for most of these patients, really our mainstay of therapy tends to be artificial tears as often as a patient can practically do, and warm compresses and lid scrubs as with any other dry eye patients. And, safety checks like avoiding contact lenses and really making sure that the patients are aware of their visual acuity and their limitations, especially when they are kind of in the midst of some of their ocular side effects. And, just as we talked about, steroids do not seem to have a role in these patients. We do not know what some of our other dry eye therapies like Restasis or Xiidra do in these patients. I generally tend to keep them on them if they're already on them, but do not start them on these medications unless absolutely necessary, just because of how many other medications they are on and how much of their other medication burden that they sort of have to go through day by day. But, treat the patient in front of us is, I guess, general philosophy. Yeah. And thank you for everything you do for these patients here.
Yeah, thank you. I mean, I think it's really, I think we can't stress enough the importance of that collaboration to really get this to patients. When patients come to Bellamav as a potential treatment option, they really don't have many other treatment options available. And so making sure that our partnership enhances their potential for response. As I showed you in the duration of response curve, it's one of the longest in refractory myeloma. It really is very key and critical, I think, to making sure we give the patient the best opportunity to get benefit from the therapy overall. And so I think with that, this has been a great discussion. Thank you so much for all of your insight here. We're just along for the ride to help partner as well, but we really couldn't do any of this without the collaboration, again, between ophthalmology and oncology.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/DMW860. This educational activity is supported by an educational grant from GlaxoSmithKline.